it is not in slideshow.
Yeah.
So now it's good.
Yeah, now it's okay. So, which you see two pictures of asymmetric faces. Which of them is likely to recover faster, the left one or the right one? And which of them would need an echo? Which of the babies? So how do I get these answers?
So the participants will put their answers in the chat box.
Chat box, okay.
Yeah. So the students can like say number 1 answer and number 2 answer. So we can wait for like 30 seconds for everyone to answer, and then you can proceed.
So, okay, I think the people are saying left, right, and upper motor neuron, lower motor neuron. But if you can type what is the diagnosis, it will be good. Then we can discuss about it. So the one on the left, this one is showing a lower motor neuron type of weakness. You can see that there is deviation of the mouth towards the right side, and there is loss of nasolabial fold here, and there is an opening of the palpebral fissure is there, where there's an incomplete closure of the eyes is there. So this is a facial nerve palsy, which we find during, and it's a part of the birth injury. At times it can be a congenital facial nerve palsy because of some kind of disorders like Mobius syndrome and all. But that's very rare. But usually it is a part of a birth injury, and they usually recover in about 3 to 4 weeks, and we don't have much of the problems. Whereas the one on the right side, here you can see that there is a complete closure of both the eyelids, and there is a nice nasolabial folds on both the sides. There is only deviation of the mouth towards the right. So this is a picture of this is an absence of this anguli oris. And this is usually associated, because this is unlikely to recover, but it will not have any kind of problems. And they have at times some kind of associations with the heart disease, and at times they can also have congenital dislocation of hip also. So you need to have a more careful examination in this case. So we have absence. So I think they are right. They are presented it. Okay, fine. Next condition. Why should MRI and echo be done in this baby? You can see on the left there is a baby, and on the right you can see an MRI. Can you tell the diagnosis and okay, fine. I think most of them have answered it right. So there is this is an Ashleigh macules present, So whenever a baby, these kind of babies, it is a neurocutaneous marker. And if they present with seizures, uh, unexplained seizures are there, then one has to completely open the dress and see whether there's such kind of neurocutaneous markers like these, or at times in incontinentia pigmenta, you can have linear with vesicular lesions also. And this MRI shows here there are subependymal subependymal tubers. You can also find in the cardiac examination, you can find the rhabdomyoma, and in the eye examination, you can also get to know the retinal tubers. So, which of the following statements is true? Donor milk is pasteurized to minimize the risk of infection. Pasteurization preserves all the immunological benefits of the human milk. The nutrient composition of banked donor milk is comparable to the preterm human milk. Premature infants who receive donor milk demonstrate similar rates of weight gain as those who are fed preterm mother's milk or premature formula. I think most of them have answered it right. It is one only, and some of them have mentioned 2 and 4 also. So the first one is right. It says that it is pasteurized, but pasteurization does not preserve all the immunological benefits like macrophages, lymphocytes, then lysozyme. These live immunological features are not preserved in them. And the nutrient composition of the banked milk is obviously not the same as the preterm milk, because it is taken from the term mothers, and it is usually pooled. So from 3 or 4 mothers, it is pooled, and the protein content can be even less than 1, because they are not taken immediately after birth. They are taken after a few weeks or few months after birth. So the nutrient quality is likely to be low in them. And babies who receive predominantly donor milk, they have a lower growth rates, and even the cognitive outcomes in them are not as comparable to those who are fed premature mothers only milk. So it is not an ideal milk, but only thing is that if you do not have the mother's milk, then sometimes in rare instances you can use this donor pasteurized milk. Then next is we have a 39-weeker baby weighing 3 kgs, was born to G3P2 mother with no risk factors by elective LSCS. The baby was given tactile stimulation and a brief period of oxygen at birth. ABGA scores were 6 and 8. The resident did a GRBS at 30 minutes, and it was 29 milligrams. Baby was given a formula feed, and later it increased to 39 milligrams. So the question is, when should the initial GRBS be done? So, and secondly, what are the risk factors for early hypoglycemia? Which neonatal reflex is useful to determine symptomatic babies? And how does glucose homeostasis differ in breastfed and formula-fed babies? So let us see the answers. So this is Okay, they're answering 1 hour, 2 hours, acidosis. There are no risk factors not required. Fine. I think some of them have answered it right, because this was a baby without any risk factors. So GRBS was not essential. The blood sugar estimation was not essential in the first few hours of life, because this 29 milligrams is a physiological drop, and it is likely to increase. And if at all it is done for a baby with risk factors, it has to be done half an hour after the feed. It shouldn't be done before the feed. And the risk factors has already been mentioned in the clinical case. He has told about late preterms, SGA, IDMs, LGS. So these are the ones where we have to do. These are the risk factors, and only them after giving the feed within the first hour, half an hour after feeding, we can do. And what is the reflex? We can do the Moros. So if the Moros is exaggerated, that is one of the signs of early hypoglycemia. And the glucose homeostasis refers in breastfed, because the breast milk quantity is insufficient, but they maintain the brain does not get any kind of injury, because it is the ketone bodies. So the ketone metabolism is more active in babies who are taking the breastfeed when compared to the formula fed, and hence even though they have a lower blood sugars, they do not have there is no risk of brain injury in them. Okay, next case, we will go to the next case. A 34 weeks poorly controlled diabetes mellitus, previous history of stillbirth at 36 weeks, and emergency C-section was performed for prolonged fetal bradycardia. Baby was started on CPAP in the delivery room and was shifted to the NICU because the baby had RD. And baby in the NICU required 50% oxygen. ABG showed 7.22 pH, PCO2 55, 62 of PO2. X-ray showed inadequate lung expansion. The CPAP was increased to 8 centimeters. FiO2 was also increased. The ABG now showed 7.22, 60 of PCO2 and 448. The right upper limb oxygen saturations are 92 and the lower limb oxygen sats are 82. So what should be done now? Okay. I think most of them have answered it right. The ideal thing is not to get confused with the pulmonary hypertension because of the difference in the oxygen saturations between the preductal and the postductal SATs. What should be done here is ideally the baby has to be intubated. There is acidosis, there is hypercarbia, the baby is requiring higher oxygen, has to be intubated and ventilated. So that's the most important thing. This baby was intubated, perfectant was given, and ventilated settings were 20/4 with 0.35. This one TI. FiO2 was increased to 70%. There was no increase in the oxygen saturations, and the echo done showed a right ventricular systolic pressures of 55, and the PO2 was 45. Iono was started, There was no increase in the oxygen saturations after 15 minutes. ABG showed 7.22, 58 of PCO2 and 64 of PO2. X-ray is ground glass and hazy. What are the reasons for no improvement? Rule out air leak. Surfactant has been given. I think some of them have answered PPHN, TA, PVC, inotropes, high secondary surfactant deficiency, PDA. I think, see, what is evident here is that in spite of intubation and ventilation, the baby's lungs have not expanded well. So this baby, in spite of giving a dose of surfactant. So here, what is important is we have to optimize we have to optimize the ventilation. So, and the X-ray is still showing it is hazy and ground glass. Whenever the lung is not expanding, INO will not work. This pulmonary hypertension will not work. This INO will not improve the pulmonary hypertension. So what has to be done now is to go for a higher mode of, I think Khushbu has answered it, that at this point of time we need to go for high frequency oscillation. So the high frequency oscillation was started. There was transient improvement of the oxygen sats to 97%. However, within 30 minutes, the preductal oxygen saturations decreased to 85, and the ABG showed after 2 hours of initiation of INO, 7.27 of pH, 38 of PCO2, and 49 of PO2. X-ray showed a mild increased haziness and mild cardiomegaly, and echo showed right to left shunt at the level of PDA, but left to right shunt across the PFO. What is the possibility now? Why did this baby not improve even after giving INO and after starting this one also, HFO? Anybody? I don't find anybody answering this. So see here, it is very clear that it is TA, PVC, shock, PDA started to close. Okay, so I think Rajesh Kumar has rightly answered. I just don't know, is this the host, Rajesh, or is it a yeah, the host? So he has rightly answered, saying that this is an LV dysfunction. So whenever you have an LV dysfunction, the left atrial pressures will increase and there'll be a left to right shunt across the PFO. So whenever there is like this, then giving INO will not help, because it will only bring more blood to the left atrium and will lead to increase in the left atrial pressures, and it will lead to left to right shunt across the PFO in spite of right to the left shunt across. So what is important is whenever you start the baby on INO, it is important to see that, ensure that the left ventricular functions are good. If the functions are good, only then you should start. Otherwise, INO will not work. I have, I think, 2 more cases, short cases only. So we have a baby who is born to a 32-year-old G2P1 mother by elective LSCS. Free flow oxygen was given at 10 minutes of life for central cyanosis. There was minimal improvement in the skin color. At 20 minutes, the baby's face, oral mucosa, and tongue were blue, but the abdomen and legs were pink. The baby is breathing comfortably. Bilateral air entry is good, but S2 is loud. Peripheral pulses are okay. X-ray showed a well-aerated lung fields, and the pulse oximetry from the right hand and left foot are 60 and 80% respectively. ABG showed 7.32 of the pH, PCO2 of 40, and only 34 of PO2. And after giving oxygen, after doing the hyperoxia test, there was only 40, the PO2 was only 40 mm. What is the most likely diagnosis in this case? I think Dr. Hetal Buddh has answered it right. He has, and also I find somebody called as Joseph Swapna have answered it right. The most likely diagnosis whenever there is a reverse spinosis, and here the baby is otherwise comfortable. When you have a reverse spinosis, it is mostly a case of TGA, and you can easily diagnose this condition by echocardiography. And X-ray we will show some evidence of a narrow pedicle also. So this is right. And we have the last one. A 28-weeker 1 kg baby at corrected gestational age of 33 weeks was found in a morning round to have a murmur. The capillary filling time was okay. The blood pressure was all right. The output was good. Echo showed the PDA of 3 millimeters. There was dilated LA and LV. LA-AO ratio was 2.2. LBO was 300 ml per kg per minute. In the aorta, there was a mild diastolic reversal. So how will you treat this? Will you treat this? So people are saying it is an HSPDA, we have to treat, we have to give ibuprofen. I think this is almost 5 weeks old. So giving ibuprofen and paracetamol at this time will be of no use. First of all, it will not close. The chances of pharmacological closure are so low. And firstly, most importantly, the baby is asymptomatic. So whenever there is an asymptomatic PDA, we do not consider the echo findings at all. Echo findings are only for the diagnosis, but clinical features are important. All this baby requires is only a follow-up and a cardiology consultation. But otherwise, there is no need for you to do active management in this case. At any age, PDA should not be treated unless the baby has clinical signs. This baby is growing well, just a murmur is there. So all we need is, because many of them will close down. And if they do not close and they have failure in the future, then they will require either a surgical or a percutaneous coil closure. I think I'm done, Kavita. I think my presentation is over.
Thank you so much, sir. It was a excellent learning session this half an hour. Even the clinical case presentation, all your advice on clinical examination was very, very helpful. I think the students have really benefited. Thank you so much for being part of this session, sir. Thank you so much.
Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Anurag and Dr. Zamir. So,
Thank you, ma'am.
we can end the session now.
Yes.
Okay. Thank you.
Thank you, Dr. Ravi Shankar, so much.
Thank you, sir. Thank you.
Thank you very much.